Okay, thank you so much. Okay, so we're going to go ahead and start because I think the coffee hour, a couple of hours go pretty long. But so whoever has made it, welcome to this course. I am basically an add-on to this course. This course was originally was submitted by Dr. Diofa, who is one of the endocrine pathology faculty and head and neck faculty at Penn in Philadelphia. Okay, that's fine. She submitted this course for Dr. Lavolsi, who most of you know, an amazing endocrine pathologist and general pathologist. She passed away in March, so I was requested to take over her part for this course. So, I feel lucky, at the same time sad that I have to fill in for her, but she has left a great legacy. So, and I'll try my best to do. I know I will never be able to do as much as Dr. Lavolsi did, but I will try my best for this course. So Dr. Diofa is, as I said, a junior faculty at Penn. Her interest lies in endocrine and head and neck, as well as cytology, which is a great combination to do these things. So we are going to talk about 2 topics each, and it's basically is going to be the new entities or the entities that existed and have been renamed in the new WHO classification and how they affect cytology diagnosis. And we are also going to bring in some multidisciplinary approach to it. So, Nicolina?
Thank you very much, Dr. Baloch, for the introduction, and thank you to everyone who bright and early came to join us to discuss some challenging and new topics on thyroid pathology. So we do not have anything to disclose relevant to this talk, neither me nor Dr. Baloch. I will be leading the first half of the talk, and then Dr. Baloch is going to follow, and we are happy to take your questions and summarize towards the end. So just a very, very brief introduction regarding thyroid. As you know, the incidence of thyroid nodules is quite high, reaching up to 20%. And most of them are discovered incidentally. We have developed a pretty good algorithm, diagnostic algorithm that is multimodal and stepwise. And it starts with the clinical presentation and the clinical findings, moving on to whether this nodule is a functional nodule or not. And then subsequently, we are evaluating the nodule under sonography, ultrasound findings. And if warranted, the patient will undergo a fine needle aspiration, which is a minimally invasive procedure, as you know, and potentially molecular testing, depending on our findings. The whole purpose of this algorithm is to provide with the clinician and the patient with a kind of calculated risk of malignancy, and this will guide their clinical management and decision-making. So this is a picture that is adapted from the newer Bethesda for thyroid cytology. And as you can see here, our patients who undergo fine needle aspiration, they can be kind of subdivided based on the cytomorphology into different categories, up to 6. If the nodule is benign, all is well, and the patient can be followed up with surveillance and subsequent ultrasounds. If the nodule is malignant, the clinicians and the patient have already a pretty good idea that they will have to undergo surgery. However, we have these intermediate categories with atypia of undetermined significance or follicular neoplasm or suspicious for malignancy categories, where this is kind of more diagnostically challenged. And as we can see, we will see in our down the line in our presentation, cytology has its limitation, and therefore molecular testing becomes quite relevant and significant in order to be able to kind of decipher these challenging cases and put them in the correct diagnostic bins, because it is very important, if a nodule is benign, to be followed up by ultrasonography rather than to undergo a non-necessary procedure. So molecular testing is important diagnostically, but also gives us a significant information regarding prognosis if we have associated mutations that are kind of clinically relevant. And then in the cases of malignancies, we nowadays know that there are additional mutations and there's additional genetic landscape that can predict very good potentially targetable mutations and lead to targeted and individualized therapies. So very significant role of molecular testing nowadays. So for this presentation, we will also present to you cases and kind of go over through our diagnostic kind of challenges in a case-based manner. So my first patient is a 60-year-old female. She was involved in a car accident and she underwent a CT of her head and neck area. During that time, she was found to have an incidental thyroid nodule, like most of our patients. And this nodule was located in the left lobe, lower pole. It measured 2.8 centimeters approximately. It was isoechoic, solid, with smooth margins, and it was taller than wide. Some of these words for you are buzzwords, and we know. Therefore, the decision, this was called the TIRADS4 nodule, and therefore the decision was made to proceed with an FNA biopsy. And for those in my audience who are cytopathologists, I love my cytology, so these are the two main stains that we will see when we examine our cytology specimens. On the left hand, you have your diff-quick stain, and this is what our cytotechnologists and our cytopathologists evaluated while they were there in the rapid evaluation. And you do not have to be a cytopathologist to know that there's something going on, right? We have these groups of cells that have really enlarged nuclei with nuclear elongation, irregularities in their nuclear membranes, and additionally, you notice that they have kind of a disorganized haphazard pattern. And the beautiful Papanicolaou stain on the right side of the picture shows you even better these nuclear details, and I hope you can appreciate that the cells are significantly enlarged, the nuclei are significantly enlarged, and they have this that we like to call very pale, fine chromatin with a sharp nuclear membrane and a subtle peripherally based nucleus, if you can appreciate. And then in the center of the picture, I don't know if I can, in the center of, okay, no, I don't know, sorry. In the center of the picture, you might appreciate some intranuclear grooves. All these features that I'm describing you are, for all of us, buzzwords, right? However, we did not see this specimen to be very cellular, so the cytopathologist who signed out the case went with an kind of intermediate diagnosis with a TPA of undetermined significance, classified it as a Bethesda category 3. So the patient underwent subsequent molecular testing with Afirma, and HRAS variants were identified. So this was an intermediate risk lesion, and the decision was made to proceed with a surgical management. And here I have this low magnification picture. It is a complete cross-section of this patient's lobe. And as you can appreciate in the periphery of the image, we have the normal thyroid gland, and you can see these variably sized follicles with abundant colloid. And in the center, I hope you can very easily discriminate that we have our lesion of interest. It is a very well-demarcated lesion, and there is a very fine, subtle capsule that you can appreciate, and you can almost draw a line around it. And another clue here for this lesion, you notice that the pattern that we see, we don't see any fibrovascular cores, again, buzzwords, and any fibrovascular cores, we see a very uniform follicular pattern lesion. So then, your diagnostic checklist, you have your differential diagnosis kind of rolling in the back of your head, and these include follicular pattern neoplasms of the thyroid, including follicular adenoma, follicular variant of papillary thyroid carcinoma, follicular thyroid carcinoma, and our new kid in the block, NIFT-P, non-invasive follicular thyroid neoplasm with papillary-like nuclear features. And all these lesions, to no surprise, share kind of similar genetic landscape, and they all share RAS mutations. And some these are kind of like simplified, but PP are gamma rearrangements as well. So for this particular patient, the molecular testing does not help us further refine our diagnosis. But we go back to our lesion and we start looking more carefully. This is another section of the same lobe, and you can see that the nodule almost entirely takes over the lobe of the patient. The capsule is still very well retained and fine, and the pattern remains follicular. However, when you notice on the right-hand side images, the nuclear features of papillary thyroid carcinoma are identifiable. We have the nuclear enlargement, we have the clearing of the chromatin, we have the subtle peripherally placed nucleoli, and if you have a strong imagination, a very good eyesight like I do, you will notice the intranuclear grooves that we saw in the cytology specimen. So now that you noticed the features, the nuclear features of papillary thyroid cancer, now you narrow down your differential diagnosis, right? So if anyone wants to shout out, otherwise we have our NIFT-P lesion, okay? So why does it become important? Why all this fuss about this entity? NIFT-P is a relatively new kind of term that was introduced back in 2016 when we retrospectively reviewed cases that in the past had this follicular pattern, were very well encapsulated or demarcated compared to the adjacent thyroid tissue. These were usually put in the category of encapsulated follicular variant of papillary thyroid carcinoma. However, when we looked at their clinical behavior, we saw that they had a much more indolent course. And therefore, it felt that it was no longer necessary to include the word carcinoma for this lesion because they did not behave in such an aggressive fashion. And then when we looked, we went back after the introduction of the criteria, and we will go over those. When we retrospectively reviewed the cases, we identified that there is an approximate prevalence worldwide of 10% of NIFT-P. There is a female predilection with a 5-to-1 female-to-male ratio. And also there's significant genetic variation. So if you notice in Asia, the prevalence of NIFT-P is only up to 5%, whereas in Western countries it reaches up to 20%. And we believe that these kind of changes and discrepancies are more due to the inter-observer variability and the application of the criteria rather than through reflection of, a different prevalence of the lesion in different geographic areas. So, like Dr. Baloch mentioned, I'm a junior faculty, so I like my definitions, I like my criteria, because it keeps me consistent. So I really appreciate when, I am offered with a clear-cut definition of what the lesion should be. So for NIFT-P, we need, like we said, a follicular pattern lesion that is very well demarcated or encapsulated and has the variable nuclear features of papillary thyroid carcinoma. We should look out very carefully, however, because now we are removing this lesion from the basket of malignancy and we are putting it in the more benign, more indolent lesions. And we should make a very careful assessment for capsular invasion and vascular invasion. This should be absent, and we should be sure that this is the case. And then when we look at the architecture of the lesion, again and again, this is my topic, so I'm talking about follicular pattern lesions. You should not see any solid areas, you should not see any insular growth, you should not see trabecular growth, more than 30%. You should not see necrosis, and you should not see a high mitotic activity. Your mitosis should be less than 3 mitoses per square millimeter. And then regarding the architecture, another kind of slightly controversial topic in the literature is the papillary formation. So in the criteria, we say no Samoma bodies, and we all know that Samoma bodies are kind of make us set the alarm in our heads that we are dealing with fibrovascular cores that become kind of like a vascular and then calcified. So this would be a hint that you had some fibrovascular cores and papillary formation there. And then the well-formed papillae, here there is a slight controversy in the literature, and I'll go over that. We know that we can allow some simplified or rudimentary papillary structures to be there in the lesion, and that is okay, but we should not see well-formed fibrovascular cores that are lined up with these very atypical cells that bear the features of papillary thyroid carcinoma. And this stems from these studies that I mentioned before that looked retrospectively at cases of NIFT-P when we applied the criteria. And we saw that for the vast majority of these retrospective studies, the course was very indolent. However, when we applied the criteria of less than 1% papillary formation, you can see in the bottom the last two papers that mentioned that we had some adverse outcomes. These adverse outcomes included metastasis to regional lymph nodes in the central compartment, either at the time of the surgery or subsequent. And when we look at the literature, usually these metastatic foci were very small, less than 2 millimeters in size. And also, in the last column, in the additional features, you might notice that in the cases where we noticed that we had adverse events with the microscopic nodal metastasis, there were also cases, up to 10% of the cases of NIFT-P, that bear BRAF V600E mutation. So that is something else to keep in mind. So all this observation kind of raised the flag. So how strict should our criteria be, right? We do not want to undercall, or we don't want to overcall a lesion. So subsequent studies have shown that even if you keep the criteria of less than 1% true papillary formation in these lesions, the adverse outcomes are minimal, less than 1%, and there is no effect in the survival of these patients. So in 2018, the criteria for NIFT-P were revised, and these are the new criteria, including primary and secondary criteria. So the primary criteria include, like we mentioned, the encapsulation or wear demarcation, the follicular pattern, absence of capsular and vascular invasion, less than 1% well-formed papillae still there, so no well-formed papillae should be seen, no samoma bodies, and of course no trabecular insular growth, necrosis or mitosis, like we mentioned. And then in the secondary criteria now, these are helpful. They are not required for the diagnosis of NIFT-P, but it is something for us to keep in mind. The lesion should lack a BRAF V600E mutation, or detected either by molecular testing or immunohistochemistry, or additional mutations that bear bad prognosis, high-risk mutations such as TERT or TP53. And this has trickled down to our Bethesda system, because like we said, everything we do is in order for the patients to avoid unnecessary procedures and better guide our clinicians for the management of these lesions. So if NIFT-P is removed from the malignant category, you will see that we have a significant decrease in the risk of malignancy, particularly, as you can appreciate in the middle of this table, for the intermediate categories, including the ATP of undetermined significant, follicular neoplasm, and suspicious for malignancy. And then here, in the newest Bethesda, you can see that if I have in red the adjusted risk of malignancy, if we exclude the nodules that are diagnosed as NIFT-P, and you can appreciate that the main decrease in the risk of malignancy was observed in the suspicious categories, because as you noticed from our cytology specimens, the nuclear features in themselves are quite worrisome. However, this lesion doesn't end up being a papillary thyroid carcinoma. So, like everything pathology, and we keep on saying that, I'm sure in other lectures that you went, everybody mentions that, everything starts at the bench. And it is very important to keep that in mind. The importance of appropriately grossing the specimen is paramount. we mentioned that in order to be able to exclude capsular and vascular invasion, in order to exclude the presence of fibrovascular cores, we need to examine carefully the entire lesion. So we need to make sure that the entire interface between the nodule and the surrounding thyroid parenchyma is assessed. Therefore, when we receive a thyroid specimen, we, of course, weigh, measure, describe everything we see. We use also whatever diagnostic tools we have in our ability. So ultrasound is our friend. The ultrasound can guide us in identifying whether we have single nodule or multiple nodules. We ink our specimen, and then what is the best way to go about processing the specimen would be to serially section from superior to inferior the right and left lobes and perpendicular the isthmus. Once you identify the nodule, and if you have, for example, a single nodule that is up to 5 centimeters in size, you should submit the entire capsule with the interface between the normal and the nodule, as shown here, and I have a subsequent image that is real life. But if your nodule is larger than 5 centimeters, then you should make sure that you include one additional section for each additional centimeter of the lesion. And this is, and thank you to Dr. Baloch for providing me with some of these slides. This is a beautiful example of how the thyroid should be grossed. And this is the sections that our grosser took, our resident or our PA, and they show a beautiful interface between the normal thyroid parenchyma and the lesion. And you can appreciate that you have, especially in the last cassette, you have this nice little rim of benign thyroid with a thin capsule. And this is the same as you can see in these whole slide images of the slides on the bottom, and you can appreciate the demarcation between the benign and the lesion. So many times in clinical practice, you may consider yourself lucky. You encounter a lesion that has a follicular pattern, right, like I mentioned. And then in the little box in the middle, you appreciate very nice nuclear features of papillary thyroid carcinoma. And you want to make sure that you don't miss a cancer. Otherwise, you can very nicely lump it into the NIFT-P category. So when you look at your interface, you can have a beautiful mushrooming, we like to call mushrooming of the tumor through the capsule and finding itself on the opposite side. So for us to call capsular invasion, this is one again of the topics that is slightly controversial. For us to call something capsular invasion, you need to be able to see the whole, the tumor transgressing through the capsule of the lesion. And if you find that, and you know, in your first section, you consider yourself lucky and you saved yourself from further trouble. However, as we all know, things in real life are rarely so simple, right? So many a times you will get a nodule that is well demarcated. Your grosser says, but you know, I see a very well demarcated nodule that has a capsule, and you can see the beautiful pictures that they took for you to show that indicate that this could potentially be a more indolent lesion. And this is a picture that shows that, of course, this corresponds very well to what you see under the microscope with a very nice capsule that is retained there. However, you can see that on the right, larger image, you start noticing some microscopic foci where the tumor is truly trying to go through that capsule. And this should set off the alarm inside your head and make you pause for a second. Because yes, this lesion does not meet the criteria by definition, right? The tumor does not mushroom, does not go through the capsule, but is definitely trying. So what do you do next? Remember, deepers are your friend. You can do multiple levels and be able to identify, as you can see in the bottom picture on the right, the tumor actually breaking through and finding itself on the opposite side of the capsule. So the power of deeper, never underestimate. Take the time, take deeper sections. As a trainee, I never appreciated deepers. My attendings used to say deepers, and I used to be like, oh, this delays me so much, I have to. But as an attending, I truly have learned to appreciate them. And this is my advice to you. Take your time and look carefully. And if you have any doubt, deepers may save you from further trouble. So for capsular invasion, there are other challenges that we need to keep in mind, right? Because all of these nodules, remember, they have been biopsied priorly. So the FNA tract and the prior biopsy changes, you know, we are all very happy to see them there, and they help us in our diagnostic algorithm like we saw. However, they can create artifacts that can put us in trouble, because as you can see, I have two pictures that are characteristic of FNA tract changes. And in these areas, you start noticing fibrosis, you can start noticing hyalinization, dropout of the follicular cells, and through the FNA tract, you may start seeing impingement of the capsule. You may see kind of capsular distortion that may start worrying you for capsular invasion, and you may even sometimes see the tumor bulging through those areas, mimicking pseudoangioinvasion. So you have to be careful that this is another pitfall, this is another thing to have in the back of your mind. And sometimes you may be lucky and you can see the, hemosiderin-laden macrophages, you can see the area of granulation tissue, and you can get those hints. But sometimes if it was the biopsy happened a long while before, you may find yourself in a bind and kind of second guess yourself whether what you see is truly what you're dealing with. So before throwing your hands in the air and freaking out, you have tools. We always have extra tools. We are lucky to have extra tools. So in order to be able to discriminate between a thyroid cancer and a more benign lesion, you could potentially use an HBM1 immunostain, which will be positive in your cancer cases. Remember, we said we have the dropout, we have the hyalinization, the fibrosis. Follicular, and Dr. Baloch, I'm not going to talk about it. Dr. Baloch will go over medullary thyroid carcinoma. And this can mimic anything. It can present as a follicular pattern lesion. And you should not forget to test about it with Congo red if you see areas of amorphous material and hyalinization. And your calcitonin stain can help you out as well. Like I mentioned, my best friend, deeper sections. And of course, we don't practice alone, right? Whenever you have a question, I have really good friends and mentors who I always ask for their advice, and I take what they say very seriously. We can show our cases to our colleagues, and we can keep on learning from each other. So you can always ask a friend. There is no shame in that. And to make things even more complicated, remember that not everything that is in the thyroid area is thyroid, right? So there is a chance that your clinician may biopsy something that is in the thyroid, and it could potentially be an intrathyroidal parathyroid adenoma that can mimic a follicular type lesion. You can kind of imagine some abortive follicles there and then more solid growth pattern. So this is another thing to keep in mind. All these are things that we encounter daily, and we need to kind of have them in the back of our heads in order not to miss them. And then I go to one of my favorite controversial topics, which challenges me personally quite a bit when I look at my thyroid cases, the vascular invasion. So not every tumor cluster that is identified in a vessel is considered a vascular invasion, right? So nowadays we know that the tumor has the acceptable criteria include the tumor being adherent to the vessel wall, being able to show that the tumor is eating up and going into the vessel, and the association with fibrin thrombus. Most of the time you will see the tumor being lined up by endothelium. The endothelium may be retained or focally disrupted, and this is also another hint. The focal disruption of the endothelium is another hint that we are dealing with through angioinvasion. However, this topic again is very controversial, and there is a lot of inter-observer variability on what we accept as being as true vascular invasion. In this particular case, you see that the tumor is attached to the vascular wall, and you have your endothelial cells that are disrupted at the focus of tumor. And this is another example where you have the tumor growing into the vessel. There is association with the blood, and you see like you have the hemorrhage in the vessel wall, and the endothelium is right there. So this would be a case again of that would be called justifiably so vascular invasion. But you can have mimics, like we said, of vascular invasion. You can have pseudo angio invasion. And this can make things a little bit more complicated, particularly if this happen around the area of the FNA tract and your thresholds need to be higher. But a tumor sitting in a vessel, a tumor that is not associated with a fibrin thrombus, and that does not appear to disrupt the vessel wall. This again is one of those cases where even amongst experts there is no definitive consensus on how to approach these cases, and this becomes challenging because finding a focus of vascular invasion will put your lesion into the carcinoma category versus the indolent behavior, and of course you do not want to do that for your patient, either undercall or overcall such a lesion. So you may be lucky. In the left-hand side picture, you can see that the tumor is eating up the vessel, and you can identify a focus like that, and you may feel that, okay, I'm comfortable calling that. And again, if you have fibrin associated with your tumor inside the vessel, lined by endothelium, you can go ahead and call it. In case you're uncertain, you can use endothelial markers. You can do CD31, CD34, ERG, and CD61 for identification of fibrin thrombus in some cases. Just briefly, I wanted to mention before I move on to my second case, remember that you can have oncocytic type NIFT-Bs because things are not complicated enough. We can have oncocytic type NIFT-Bs, and we can also have sub-centimeter NIFT-Bs, okay? So I'm moving on to my second case. This is a 56-year-old female. She was found to have incidental thyroid nodules, and in this particular case, she had two nodules that were identified in the left side. One measured 3.5 centimeters. It had a mixed cystic and solid consistency. It was hypoechoic and lobulated. And immediately adjacent to it, in the same area, or abutting or coming off it, was a second nodule that measured 1.6 centimeters. It was solid and hypoechoic. Both of them were thyroids 4. Both of them were biopsied at the outside institution and called Bethesda category 3. They were followed by AFERMA testing, which identified again this intermediate kind of risk mutations and RAS mutations for both nodules. Therefore, the team decided that the patient should undergo a left subtotal thyroidectomy. And this is what we received. And you can see, I appreciate that my sections are not the best, but it was a friable tumor. And I hope that on the left image, you can appreciate the normal thyroid parenchyma. And then I have made a nice scribble for you that maybe you can appreciate the capsule being present there, discriminating between the lesional and the normal thyroid tissue. And at the bottom of the image, this is where your attention should be directed, where you start noticing that the morphology of the lesion is identified outside of the confines of the capsule, right? So we have the higher magnification on the window on the left, and you can see that the tumor is kind of transgressing through this capsule, is breaking through and is finding itself on the opposite side. So you're dealing with a follicular pattern lesion that is encapsulated and has capsular invasion. And I'm already giving you my clues and high magnification pictures, and you can appreciate that you have nuclear features of papillary thyroid carcinoma here. And hopefully in your diagnostic checklist, you are correctly identified in this lesion inside as a follicular variant of papillary thyroid carcinoma. So follicular variant of papillary thyroid carcinoma is a lesion that has follicular pattern, is composed of small to medium-sized follicles, and has variable nuclear features of papillary thyroid carcinoma. So here, now we have to be careful because there is a further subdivision in the follicular variants of papillary thyroid carcinoma. Now they are further subdivided in encapsulated and infiltrative. And here, this particular case was an encapsulated follicular variant of papillary thyroid carcinoma because it was partially lined with a capsule that was, of course, disrupted. However, the capsule was there nonetheless. When we talk about encapsulated follicular variants of PTC, if we have only capsular invasion, this will be a minimally invasive encapsulated follicular variant. But if you have angioinvasion, this would be best classified as an encapsulated follicular variant of papillary thyroid carcinoma with angioinvasion. So again, angioinvasion and capsular invasion are two things that we are hunting for. And these lesions, it's important to kind of set them apart because they have the same genetic landscape and they have the same mutations and biologic behavior as your follicular adenoma and follicular carcinoma categories, and they like to go to metastatic sites such as the lung or the bone less frequently than you would see them in the lymph nodes as your papillary thyroid carcinoma. And this is your friendly reminder from your cytopathologist that cytology alone will not be able to help you pinpoint correctly what the lesion is. If I showed you either images on cytology, they both look identical. However, putting everything together with the ultrasound with the sonography images, your gross examination, and the images of the capsular distortion and invasion, then you would be more able to classify the lesions correctly. And if you look at the Bethesda, we are focusing today, my talk, in the middle group that has this intermediate kind of risk lesions, this range of lesions from more benign to more malignant. And these lesions have the same cytologic features, they have same genetic landscape, and this is why it becomes so challenging for us, because it almost forms like a spectrum that requires us to kind of examine carefully and thoroughly the lesion in order to best classify it. And then I'm moving towards finishing my side of the presentation. I just have included pictures of the infiltrative infiltrative follicular variant of papillary thyroid carcinoma. And as you can see, it is very haphazardly arranged. There is no capsule we can identify whatsoever. You have these nests of follicular cells growing haphazardly and infiltrating into the surrounding thyroid and causing a lot of desmoplasia and fibrosis. And you identify very nice nuclear features of papillary thyroid carcinoma. And like I mentioned, we discriminate between the encapsulated and the infiltrative type just because these are behaving differently. These seem to be completely distinct from a biological standpoint as well. These lesions will bear BRAF V600E mutations, and they have increased risk of recurrence and lymph nodes metastasis compared to the encapsulated variant that I described to you before. So, like I mentioned, I like my diagnostic algorithms. I like my very clear definitions. So I have put this in there for you. Hopefully it's in your handouts, so it can kind of help you follow through your findings and kind of categorize the lesions in the best possible way. And before I conclude my end of the talk, some of you may be wondering, well, she had 2 nodules, you're only describing one. But if I were to show you pictures, and I'm showing you some here, of the entire lesion that we examined, we start noticing that in the periphery of this section, you can identify the follicular pattern. However, in the center, you have back-to-back follicles. You have solid growth, and then this is a higher magnification where you have trabecular and solid growth of these follicular cells. So this is something to keep in your mind. And then when we examine, we examine even additional sections, you start noticing that you have areas of hyalinization or potential necrosis in the center that are arising there and drop out of your follicular cells in this second nodule that we see. And these are all my cues for Dr. Baloch to come and take over and guide you through the next step of the presentation. Thank you very much.
Sorry, we're having
Technical
technical.
difficulty.
Just click it out.
I cannot find my mouse. Can we go back? There are two presentations. We were able to access both before, but not now.
You're all the way in session one, so you can scroll all the way forward. Which one's yours?
That's the one.
This one?
Yeah, there are two presentations in there. That's the one. Yeah,
What presentation did you want?
that's the one.
Sorry about that.
Okay. Thank you, Nicolino, for handling these difficult topics. We still have controversies. But I'm now going to take just a little notch up a little bit because what Nicolina handled was the low-risk tumors. And I'm going to move into something which is the new kids on the block, which are causing. So I do not have any disclosures related to these presentations, but I just put those in just to make sure that you guys know this. So this is the case I'm going to start with, and this is actually a real case. It's not a made-up case. 54-year-old, euthyroid, so there's no history of any clinical thyroid disease of hyper and hypothyroidism, sizable mass, and as you can see, this mass is pretty, has kind of irregular case, has really irregular margins, and you can see this is really hypoechoic. So this is very typical of tumors which are infiltrative, and you can see this really is infiltrating onto the edge, and it actually has a lateral neck extension also, and there was also associated adenopathy. This is the cytology, and the cytology initially in the beginning was not difficult because what you're seeing is almost this kind of papillary forming group, and in this group, as you can see, there is definitely nuclei that are elongated, and they do have these nuclear features which are suspicious or diagnostic of papillary thyroid carcinoma. The problem was in this part of the slide, which looked really funny because what you're noticing here is this really area here. Let me just highlight this. As you can see in this area, there's definitely this kind of grungy material. So we can think that this is like a blood clot or some other kind of debris, but it is very closely associated with the cells. That means it's clinging to the cells. So when you have in cytology a debris-like stuff clinging to the cells, and this is very common in actually squamous cancers that you see in the head and neck, and then I have become very sensitive to looking at this. So this is definitely looks like a necrotic debris which is clinging to the cells. And this is actually just a little more higher view of this, and you can see this is definitely necrosis. So this case actually was seen by one of my younger colleagues, Dr. Tom Hugh, and he brought the case to the morning cytology meeting where we all get together and go over cases, and he pointed out that this is definitely a tumor necrosis. So he signed it out as papillary thyroid carcinoma with necrosis, focal necrosis, and then put a note that this could be a high-grade transformation in this carcinoma. And he was actually right. This is what I got on the search path bench, and as you notice, there is really a good amount of necrosis on the top, which has a lot of cell debris, and at the bottom you can see there is definitely, you can see that there is definitely papillary formations which has the nuclear features of papillary thyroid carcinoma. So this was actually the tall cell and the papillary variant, a little squamoid, but no anaplastic carcinoma, but definitely geographic necrosis, which was very concerning in this case. So based upon this, again, another view of this, and you can see that when you see necrosis in a thyroid tumor, your head already goes into thinking about that could this be anaplastic, which is definitely something to think about because this is papillary carcinoma. It does have tall cell features, but this is definitely not anaplastic carcinoma. So the combination of the necrosis as well as the papillary carcinoma, this was classified as high-grade papillary thyroid carcinoma, tall cell variant. Let's move to the next case, which was actually a recent case that I had. This is a 59-year-old. So this is July 2019, FNA that I'm going to show you. She had a 2.7 centimeter right thyroid nodule. The other history that she had, clinical history, was really not related to thyroid diseases. There's no family history of thyroid cancer. And this is how her nodule looked like. Pretty solid nodule, kind of hypoechoic. They very definitely separated out from the surrounding thyroid gland. And what you notice is also a lot of peripheral vascularity, which is in the next, just trying to see if there is a pointer on this. Good. So I don't know whether this will show up. So you can see here, there's definitely a lot of vessels in it, but this is really a hypoechoic lesion with a little bit of irregular margins in the back. So this case was FNA, and this shows you a very monotonous population of the cells, no nuclear features of papillary carcinoma. This is another groupings where you can see there's a lot of nuclear overlapping and crowding. One must notice that there's not a lot of cytoplasm on this. But we all know when the follicular cells, lesional follicular cells, we see in cytology, there's not always, what we see is mostly nuclei. But when you have groups like this, and if you're smearing it very gently, you will get a hint of cytoplasm. This is the thin prep specimen. I'm showing you all the best slides, fields in this. And you can see there is also thick colloid here, which is, a little bit of, if you call it microfollicles, whatever term you use. But there's a very monotonous population of the cell. So this was actually classified as Bethesda 3 because of these classifications. But, this could also be a good Bethesda 4. But it was sent for molecular analysis. And the molecular analysis came back as with a Pax8 PPRA gamma alteration, which Dr. Nicolina also talked about. Now, based upon this, the risk of malignancy from this commercial test, the highest was about 70%. Now, what is Pax8 PPRA gamma? We know that this fusion actually leads to this protein formation, and this fusion is oncogenic when it comes to when you're looking at the thyroid tumors. And most of these tumors are follicular pattern tumors, and you can see them in follicular variant carcinoma, as well as follicular carcinomas, as well as in some cases of poorly differentiated carcinoma as an added fusion, because it can be along with other alterations, mostly like RAS mutations. Now, this is just a diagram to show why this is important, because now we have targeted therapy that is related to this tumor. So let's kind of move a little forward. So this patient was recommended to have a surgical excision, but this was happening around when she had some family issues, plus she had, the COVID came about, so there was a delay, and then the patient just decided that she's not going to deal with this now. So let's move forward. 2024, this now patient presents to the ENT clinic with symptoms of headache, nausea, and cannot keep up her balance, and plus this increase in the neck mass. Now, this was a very bulky mass, which was causing airway compression, and that's how she showed up in the ER, that she was in a bad condition. Now, this is what was at that point, and they ordered an MRI because they were thinking that her thyroid mass is a very different process than what is going on with her other symptoms. So the MRI showed this really bulky mass, which is infiltrating, as you can see, and at this point it was thought that this may be related to a neuroendocrine neoplasm or some other paraganglioma type progression or chordoma or something. A lymphoma was also in the differential. Nobody was thinking that this could be related to the thyroid because this is a very atypical presentation for a thyroid tumor. And now this is the core biopsy from that skull base mass. As you can see, this is a very solid growth. It does have kind of a nested appearance. And this is just a high power to show you how this is. So naturally, the endocrine, other tumors were also in the differential. But because of this neck mass, I threw in, so all the neuroendocrine stains were negative except focal synaptophysin positivity. It was positive for keratin. But this was the stains which were positive, which is thyroglobulin as well as TTF1. So this was a thyroid primary. And with a solid growth pattern, naturally you have to start thinking about that this is most likely a poorly differentiated carcinoma, which has metastasized. Kind of really atypical presentation. This is the neck mass, core biopsy. This was also FNA'd, and FNA showed the same pictures, and as you can see, very solid nested growth pattern, and this is very typical for, will be a thyroid primary, which will be the intermediate risk tumors, and this is PAX8 positivity naturally, so this is the same tumor. So this case was called as poorly differentiated thyroid carcinoma. This is what the surgical excision was of the neck mass and the thyroid, and you can see how it basically takes over the entire lobe of the thyroid. And this is the low power. And as you can notice, the first thing to notice in these tumors, it is encapsulated, has a very cellular type of growth pattern. And in this area, you notice that this is very solid. And on the low power, this is a trick. When you start to see these empty spaces, which have almost like a staghorn type quality to it, you start thinking that you are dealing with something which is not just simple follicular pattern. And on this side of the tumor, you can see it has more differentiated growth. But your eye, what goes down to exactly is this center area, which is more than what you will see in FNA-related changes. So this is more of a necrotic center on this tumor, and this is the periphery of this tumor, encapsulated, it's invading, and as you can see on the really far end of this is invading actually in the blood vessel. This is the neck mass, which was also the same tumor with the central necrosis. So this was actually called as a poorly differentiated carcinoma, which is arising in association with a follicular variant of papillary cancer, and it has extensive vascular invasion, that means more than 4 vessels, and also had extensive extrathyroidal extension. Now, when you look at poorly differentiated carcinoma criteria, which are established in Turin, which are still applicable in the new WHO classification scheme, that these tumors can be encapsulated or non-encapsulated. They can be associated with a well-differentiated component or may not. And their growth pattern is very solid, insular, or nested-like, and that's why they give rise to this look of a neuroendocrine tumor. Once you have those criteria, then you can have one of the criteria which are listed here, which is the mitotic count greater than 3, necrosis, or convoluted nuclei, which is really these darker nuclei which really you cannot see through the chromatin, and you will be able to see them. So these are not diagnostic difficulties. So any one of those criteria plus those top things will make this as a poorly differentiated carcinoma. The problem is how much of a tumor has to be poorly differentiated to call the whole thing as poorly differentiated carcinoma. Once you have a poorly differentiated carcinoma component, you have to mention that in your diagnosis. I follow the 1/3 rule. If it is 30% or more, I will call the whole thing as poorly differentiated carcinoma. Because there are studies which have shown that the metastasis usually will be happening from that poorly differentiated carcinoma. But that is my criteria. That was Dr. Lavosi used, and I used that, and some other pathologists who are very good endocrine pathologists use. But there's juries still out on these. These tumors are RAS mutated tumors most commonly. And when you're looking at cytology, you do have to get sensitive to when you're seeing a very cellular specimen with a lot of nuclear overlapping and crowding, and you're bringing in a differential that this almost looks like neuroendocrine. You have to start looking at things which are kind of falling off of these cells. So not everything is a debris. When you see these things kind of connected to the cell, think of necrosis, and if needed, process the whole specimen. And this is a classic case of a poorly differentiated carcinoma with that insular growth pattern, solid, and here you can see these dark convoluted nuclei in the background, high Ki67 index. And the other trick I learned is you can do a thyroglobulin stain on this, and the well-differentiated component will stain very darkly. The poorly differentiated component will be very lightly staining for thyroglobulin. Actually, that's one of the criteria. If it was thyroglobulin negative, then you have to start thinking, are you moving into anaplastic carcinoma category? Up to 2017, which is still true now because the latest edition, the 5th edition, is not published yet, which will be published basically by the middle of the next year, because the HemePath had 3 volumes of WHO, so they have to put those out first. So good luck if you do hematopathology. So naturally, the new classification scheme, this is under a different category, where these are the high-grade carcinomas, and in the high-grade non-anaplastic carcinomas, and there includes high-grade well-differentiated, which can be papillary, follicular, or oncocytic, and then poorly differentiated carcinoma. Why we have made this change? And we kind of actually fought for this change because there are still pathologists who are saying that we should not have that category. Let's keep the way things are. But when you look at the molecular profile, which is becoming very important, even if you are not a molecular pathologist or do not do molecular pathology, you know that there is like a really gradation from a very low-risk neoplasm to high-risk tumors, which will include poorly differentiated or aggressive well-differentiated tumors and anaplastic carcinomas. And there is layering of molecular alterations, and the molecular profiles tend to become more complex. So you have well-differentiated tumors, which we use in 2 big bucket lists, which are RAS-like tumors, which are follicular pattern tumors, and then BRAF-like tumors, which have nuclear features of papillary carcinoma and a really good architecture also. We have criteria how to diagnose a well-differentiated non-papillary follicular-derived tumors, which is oncocytic, and follicular carcinoma based upon their invasive characteristics. But we have noticed for a long time that even within this well-differentiated carcinoma groups, this is just an example to show you all the subtypes of papillary cancer, and you can see some of them are associated with the disease, really frequent locoregional recurrences, distant metastasis, the poster child being the tall cell subtypes. And this we all noticed. So this became very important when the clinicians started using the risk stratification on how to define these tumors. And they thought that when the risk stratification was very solid, when you had histology, and then you prognosticated based upon what the histology saw. But when you do this, you actually become too focused and miss some of the cases which should be labeled as high risk or low risk. And so this is more of a dynamic process, not a static process, because if you really use that static process, you are not going to be really beautifully stratified. The main reason, and this is a great example of it, before the 8th edition, any form of extrathyroidal extension, even microscopic, upstaged the patient to T3B. And then we realized that most of these cases that we are calling extrathyroidal extension, even on the basis of microscopy, and we know there's a lot of observer variability in that, we were actually upstaging those patients. And these patients were actually behaving like an encapsulated or tumor which are confined to the thyroid gland. They were really not behaving in an aggressive fashion. And that's why now in the 8th edition, as you know, you require the gross extrathyroidal extension that is seen or documented by the surgeon to really upstage these patients. So this is actually one of the reasons that some of the times when we follow these criteria, they are not as robust or does not reflect to how these patients really perform. So this is the criteria on really calling things high-grade, well-differentiated carcinoma, so high-grade papillary, high-grade follicular. I do want to tell you that this diagnosis has been in use for a long time, but it was just being used by a selected group of pathologists who are really attuned to that these tumors are going to behave aggressively. So these are the criteria listed that for a differentiated, you need to have that differentiated architecture, and then either necrosis or mitosis, any one of those actually is a bad indicator and can push that into this. The poorly differentiated is the exact same criteria that we use for the Turin criteria. So naturally, if we put it all together, how these tumors represent, their molecular profile, and based upon the criteria we use, we can really form a good line from a very low risk, well-differentiated carcinomas, intermediate risk where there's poorly differentiated or high grade, and anaplastic. Depending upon the size of the tumor and the criteria, so these tumors basically sit in the middle, or they may be related more towards the anaplastic side. But they are still treatable because some of these tumors do respond to radioactive iodine therapy. So these are radioactive iodine avid tumors, so that will be included in the regime. Once you call it anaplastic, they will not use radioactive iodine. Now, key things, what are the diagnostic challenges with these diagnoses? And one of the things was the mitosis. We have to now report mitosis as the millimeter square. It's a very simplified way because when you're interpreting that in the high power field, our microscopes vary, our objectives and what we are using. So it's all based, this is a beautiful article which is published in Endocrine Pathology. And the bottom line is that this is what I use. I actually use a 10 high power fields. I stay away from the areas of necrosis. I stay away from the areas of FNA tracts because then you are going to start seeing mitosis. I do go to the solid portions of it. So naturally you're looking at the hotspot areas. And if you're really robust, 10 high power fields or 10 field of views, you will be able to use. So synoptics and everything has that count now included. So not something to really worry about, but this is the different way of reporting mitosis. So it kind of brings in more stability to the diagnosis. Now, what are the challenges we see in these tumors? So as I said, these tumors can be infiltrative or can be a part of an encapsulated neoplasm, which can be the well-differentiated component. Definitely, these tumors can be infiltrated with extrathyroidal extension, no capsule in view, has necrosis and mitosis that you will see in these tumors, or these can be encapsulated tumors with a central portion or multifocal portions of poorly differentiated carcinoma. Interestingly, if you have a poorly differentiated carcinoma, so one thing that we noticed, which is very important, that if you see something which looks like a poorly differentiated carcinoma because of the solid growth pattern, and you're also seeing some mitosis, but you're not seeing necrosis, it's encapsulated, and you cannot document invasion either by doing deeper sections, submitting the entire periphery of the tumor. You cannot call it poorly differentiated thyroid carcinoma encapsulated. So there is no non-invasive poorly differentiated thyroid carcinoma. That is follicular adenoma, and it has been shown in 2 studies. So you have to have invasion to really call something poorly differentiated thyroid carcinoma. Now we note that these tumors, which are encapsulated and poorly differentiated carcinomas, they behave very differently than the tumors which are infiltrative, and that has been documented in multiple studies. What I find sometimes challenging is necrosis. So you have to avoid areas of FNA and the scar formations because that FNA tract can be mistaken for necrosis. This is very common in oncocytic lesions. So when you hit the FNA needle hits that area, it can cause almost like infarction type changes into the surrounding oncocytic cells. So if you're seeing FNA tract and these kind of dead cells surrounding this FNA tract, please do not call that as necrosis. You have to find something which is away from this necrosis. Another thing that I have seen sometimes being called as necrosis is this edematous and cystic change in these tumors. So you have an adenoma which has a solid growth pattern, has this kind of this pink material which is basically an edematous type fluid being interpreted as areas of necrosis. So you have to have necrosis which looks like a tumor type necrosis, has nuclear debris in it, and one focus, small focus, I really be careful about calling that as really pushing the diagnosis into that direction. So you have to have something that is sizable, and most of the time this is a multifocal phenomena and is usually sitting in the center of the lesion away from the areas of necrosis. So for me, this is a true necrosis which has kind of tumor debris, so you'll see a lot of nuclear debris and then it kind of matches with that solid growth. Now, as I said, that's a poorly differentiated carcinoma on the left, and this is more of a well-differentiated area which will have necrosis. So you can see, so necrosis and mitosis is something to watch for. I think it really is going to change a lot of head and neck and endocrine pathology because these tumors do behave differently. Fine needle is not good. It has been shown that all these poorly differentiated carcinomas, because it's a sampling error, they are going to end up more as Bethesda 4s. Only 25% of these cases, this is one of the studies we did, and it was multi-institutional study, and it showed that only 25% of the cases showed a mitosis, either mitosis or necrosis. So it really, and that is something to watch for in these large-sized tumors or the tumors which are infiltrating. So, if you really follow the paradigm of layering of what you see on cytology, histology, as well as on molecular, if you layer this all down, it really matches on how these tumors are going to behave, and this really is what is reflected in the new WHO classification. But what I want to point out to you, that I was lucky enough to be part of this group of well-differentiated carcinoma management guidelines, and we had to talk about poorly differentiated because they have an anaplastic group, they have a well-differentiated group, now where they should talk about those high grades, so we kind of brought them into that guidelines. So this is actually available for public view and comment. You just have to go to American Thyroid Association website, look it up, and there's a lot of clinical stuff available, which sometimes passes over the head. But as you can see that this management strategy, because they really do not want to treat everybody the same way, there is now systemic therapy available, there's radioactive iodine or no radioactive iodine, just surgery, or even no surgery in some of these cases. And this is where the molecular profile and the ultrasound really plays in. So I just wanted to put this slide here, and this is available for public view, so I'm not stealing this. This paradigm, you can see here, even in that intermediate group, they have a high intermediate and a low intermediate based upon how you sign out your cases. So this is how these patients are being managed. So it's very important that we become attuned to and a good, nicely sampled tumor on histology, not just 2 blocks, that we look for these mitosis and necrosis if we have a tumor clinically which appears an infiltrative tumor. So this is something new in the WHO, and I think it's about time that we have a different category and not really split them too much. So that was this is where my follicular pattern. So why don't I go on to my next talk, and then we will have time to really handle some of the questions. This is a 52-year-old male with a right thyroid nodule. As you can see, this tumor has really something you do not often see when you're biopsying a follicular pattern tumor. So that is the first thing. Some of the cells do have very large nuclei. So there's a random nuclear enlargement, pink cytoplasm, a lot of single cells. Some of the cells are a little bit spindly. And you can see this case, when it was taken out, it was actually a medullary thyroid carcinoma with amyloid in the background. Now, I'm going to focus more about the pathologic considerations when you're making the medullary carcinoma diagnosis, because these tumors are going to behave very differently than your follicular-derived tumors, which are making thyroglobulin. So, historically, this tumor was actually described by Dr. Robert Horn in 1951, and then actually the name was coined by Dr. Hazard in 1959. When we look at the genetics of these tumors, 75% of these tumors are sporadic, so they're not associated with any type of syndrome, but 25% are associated with familial medullary carcinoma syndromes, and they can actually be part of these. So actually, this is where our diagnosis, either on FNA or on histology, becomes very important. Now, when you look at how good cytology is in diagnosing these tumors, and I think it still holds true, that if you're looking at an FNA specimen and it doesn't look like your run-of-the-mill follicular pattern tumor, think of medullary carcinoma, because this is the thing we do not think most of the time. But I think the location and the real estate where the nodule is located really matters. So some of these are called atypical. The other thing is when you are getting a cell block and trying to do a calcitonin stain, be careful because calcitonin is a very sticky antibody and it even stains some other stuff in the background. If you do not have a cell block, the things to do now is to take a small portion of the aspirate and submit it for calcitonin levels. And or you can ask for serum calcitonin level. This is in every atlas that you will see. This tumor can have different growth patterns, can be spindly, and in a good number, almost 75% of the cases on search path will have amyloid, and that number drops to almost 20% of the cases in cytology, because this can be heterogeneous, but you can see this is an acellular material, which is almost surrounded by the cells, but this becomes very different when you are dealing with a thin prep. These are the classic cases, which show this plasmacytoid, multinucleated or binucleated cells, and sometimes you can even see spindle cells. When you do get a specimen which is tagged as medullary thyroid carcinoma, you will have to make sure that you are taking enough sections from the surrounding thyroid, because even if this, now the guidelines are that if you on FNA call something medullary thyroid carcinoma, the guidelines from American Thyroid Association and even European Thyroid Association is that the patient should go under genetic screening. Because what we are seeing is more and more older patients are presenting with medullary thyroid carcinomas. Now, when you're looking at macroscopically, one thing to notice that you should be looking for is looking for foci of necrosis or increased mitotic activity, which has been brought in as a recommendation to grade these tumors as low grade or high grade based upon any of those criteria. That means necrosis or mitotic activity or even doing a Ki-67 proliferative index. We do know that we call this tumor as a melanoma of the thyroid because it can have multiple presentations, that way it can mimic other tumors. Interestingly, these tumors also can secrete other hormones besides calcitonin. I have seen a couple of cases which have presented as Cushing's syndrome or even have caused increased melanin production, and patient has this dusky skin discoloration. So these tumors really can make multiple hormones. This is just my slide of looking at it, that it can have different growth patterns. It can even have amyloid, which can be mistaken for follicles, and that's why you can see how difficult they can be on cytology or even can have pseudomatous calcifications. This is just a case on the left is a more of a solid growth pattern that we're used to looking at it, and that's why sometimes they're called poorly differentiated thyroid carcinomas. So I will say that when you are making a diagnosis of medullary thyroid carcinoma, it's good to throw a stain on it, which is thyroglobulin and calcitonin. These tumors can be Paxate positive only with a Paxate polyclonal antibody, but if you're using a monoclonal antibody, they tend to be negative. And they can also be TTF1 positive. This is just another high power show you how the amyloid can be mistaken for a follicle formation or colloid, and you can see one of these really high, almost looks like a high-grade cell in this. So again, you should do calcitonin, and the calcitonin will also stain the amyloid because amyloid does contain procalcitonin. One of the things one has to be very careful about, not to call areas of lymphatic invasion, and this is, I have seen multiple times happen as multiple foci of medullary thyroid carcinoma. If you want, you should do a D240 or ERG stain on it to just make sure that this is not foci of lymphatic invasion, and which is very common in medullary thyroid carcinomas because a good majority of them will represent with central lymph node metastasis. So be aware of those. Now, when you are looking at medullary thyroid carcinoma, as I said, it can be sporadic, but when you are looking into the syndromes that are associated with MEN2 or 3, the 3 was formerly known as 2B, so all the literature now calls these are known as MEN3 syndrome. So if a patient has a genetic screening done, and it is a medullary thyroid carcinoma, and it is familial, proven by studies, the whole family gets tested, and the ones which have RET mutations, the recommendation still exists that at the age of 6 to 8 years, those patients should have the children in that family without even a thyroid nodule should have prophylactic thyroidectomy done, which is now becoming controversial based upon the European and some of the other data. These tumors are associated with C-cell hyperplasia, which in these MEN patients you can see on histology. Normal, we're looking at the H&E slides, but you can really highlight it by doing a calcitonin or CEA stain. Now, what happens after the diagnosis, or even before the diagnosis, if the diagnosis was made on FNA? And I think this is where it really kind of plays into how, based upon the RET oncogene mutation, what type of mutation, what are the locus of mutation, you can really see that some of these tumors are high-risk tumors, and they really are more aggressive tumors as compared to others. And I think this, and they can be associated with other stuff as noted on this slide. So this is a very important slide, and this is a great review which is available. You will have it in your handout. So I will really advise you to at least look at the tables and pictures on this, because this is how currently they are managed. Now, when we are looking for these high-grade features, which is not included as one of the diagnostic features of medullary carcinoma, but it is recommended that we look for this, is again these foci of mitosis. Interestingly, these areas of necrosis in medullary carcinoma look like chondronecrosis, because these are very solid growth pattern tumors, so you can really pick this up. And really, you do not have to worry about those areas of FNA tract as you see in other follicular pattern tumors. Now, if you have tumors which are sporadic, which are not associated with extrathyroidal extension, are small-sized, confined to the thyroid, most of the time nothing will happen to these patients, and we are talking about sporadic tumors. And this is where the grading comes from. I will say about 25 or less percentage of the cases, there's not a magic number available, which may be classified as high grade. And these are the tumors based upon either necrosis or mitosis, and actually the CAP proliferative index. So any one of this will. So what I do, medullary thyroid carcinoma, and I will say comma low grade, C note, and why I am calling it low grade. Or I will say without necrosis or increased or no mitosis. Most of them you will not see mitosis. So this is actually not such a common phenomenon. Now what I struggle with is this. As we know that C cells, sometimes when you have any increased amount of C cells on a regular H&E, it's very hard. You don't see them until they are forming a nodule or an infiltrative growth pattern, and that's where you bring in the diagnosis of micromedullary thyroid carcinomas. We do know that the C cells are now proven to be endodermal in origin, and that's why these can have multiple stains. They can stain with other immunostains, and that is one of the theory about mixed tumors, which have both medullary and follicular components. Now, when you're looking at the C-cell hyperplasia, we basically drank the Kool-Aid on this, and we said, okay, anything that looks multifocal has whatever criteria we're using, and there are a lot of criteria, was noted as C-cell hyperplasia. But I think it's now very, very debated, because this is actually one of my favorite articles, which was published in 2019, and they really looked at 118 completion thyroidectomies, the patients which have no MTCs, the medullary thyroid carcinoma, no elevated calcitonin, and no family histories. And when they count the number of C cells, it was between 5 and 36% based upon these criteria. So there are many, many criteria available. Now, one has to be careful, because you can see in the United States, chronic lymphocytic thyroiditis is more common than the goiter. In foci of chronic lymphocytic thyroiditis, you will see C-cell hyperplasia, and these patients can even have mildly elevated calcitonin levels. You will see increased number of C cells around any thyroid nodule, like adenomatous nodule, follicular adenoma, or even papillary thyroid carcinoma in the vicinity, because now we know that these tumors are endodermal in origin, and it has been shown that they do respond to TSH stimulation. So there is reasons for these to be hyperplastic or increase in number. So based upon which criteria you use, you have to be very careful, before you call something C-cell hyperplasia. So if I am using that term, I do explain that I favor this to be a physiologic phenomena, and it is because of chronic lymphocytic thyroiditis or another tumor, which is follicular-derived tumor, and not most likely related to familial. And they always will do a calcitonin stain. So that term has been used loosely in the past, but one has to be careful. This is a nodular version of a C-cell hyperplasia, and then this is what will be just the focal. They both were physiologic. That was actually next to sitting to a large adenomatous nodule. So one has to be really careful about it, and as I said, there's anything that can cause. So even I have seen cases, actually they are noted in the literature, the patients which have actually hyperparathyroidism or even next to parathyroid adenomas, you can have actually C-cell hyperplasia, as well as in patients which have severe osteoporosis. So there's not much available, but it is all in the clinical literature. Now the other thing that is, we're using the GLP stuff for the patients in diabetes and even as a weight loss drugs. In animal studies, it has been associated to cause C-cell hyperplasia, and that's why that's the warning that you will see in the commercials. But really, there's not much human stuff available on it, but that is something to notice. So the bottom line is, when you're making a diagnosis of medullary thyroid carcinoma, and I'm sure all of you are very astute at looking at it, one has to be really careful about the location of these tumors. Medullary carcinomas, when you're looking on the FNA and you're thinking of the medullary carcinoma and the nodule is either in the isthmus or in the lower pole of the thyroid, think twice. A diagnosis of medullary carcinoma near the isthmus likely, and I will bet on it, represents a metastatic lymph node which is completely replaced by C cells, because that's also the area of the central neck lymph nodes. Yes, you can see medullary carcinoma in the odd locations in the thyroid in MEN patients, but in sporadic cases, which is 75% or more of these cases, you don't see medullary carcinoma in the lower poles of the thyroid and the isthmus. So once you make this diagnosis, I think that there's a lot of stuff that sets in motion, which includes the genetic screening, because some of these patients may not have higher penetrance to have fuse and other organ involvement. Medullary carcinoma may be the first indicator. So this really sets into the motion this risk stratification on how these patients are treated. Nowadays, if the genetic studies are completely negative, the patient only has a high calcitonin level, which is related to the mass that has been called medullary carcinoma. It is confined to the thyroid gland, and the other gland is normal, you will start seeing, and we have been seeing a lot, lobectomies in these patients. So aggressive disease, but the tumors which are confined to the thyroid and have not infiltrated throughout the lymphatics and stuff can be really actually treated conservatively by surgery and just follow up. So this is something, the whole things are changing. The new guidelines are coming out, and I think they are already on the website for public comment on medullary carcinoma. So this is something to really watch for. And again, look for mitosis and necrosis in these cases. So thank you so much. This is my last slide, and I will have Nicolina come over, and please, we still have good 7 minutes for questions. Any questions? Either it was too early in the morning, it was too good, or it was too bad. So I just think that the new WHO classification is a very good classification. It really brings in what you do on cytology, and if you're doing molecular testing, it also kind of jives in what the clinicians are thinking, because the really management of, and I will tell you that even the tumors which have 5 positive lymph nodes with micrometastasis, which is less than 2 millimeter, are considered as low-risk tumors. And in some cases, those patients may not get completion thyroidectomy, because those patients most likely will not get radioactive iodine treatment. So this is becoming very different for 5 or 10 years ago, how we thought about thyroid tumors. So thank you so much. Yes? Uh-huh. Yes. So that's actually not uncommon. So if you look at the sporadic tumor data, we know that the good number of sporadic MTCs can be associated with RAS mutations, and NRAS being the common one. And these tumors, it's almost like 25% of the sporadic medullary carcinomas are RAS-driven. So in these tumors, you can see if the thyroid has the RAS is being one of the events that's happening in these nodules. One is turning MTC, and the other one is going as papillary. So, and you can see actually, if you look at the medullary carcinoma data, it's almost like up to 30% are associated with other cancers. So you can have papillary carcinoma, which is BRAF-driven tumors, and you have MTC. This becomes very common in MEN data because what they're thinking in the MEN, this is where the whole concept came of the stem cell. This is the same cells, or it's a different cells, being proliferated by the same genetic changes or by hormones, because they're also hormone-driven tumors. So that's where the TSH comes in. So yes, that is not uncommon. So up to 30% of the MEN patients can have a papillary carcinoma or a sizable even follicular carcinoma. And then you have the tumors which are mixed tumors. So you have mixed medullary. I had a case, which was a very interesting case. It was called as follicular neoplasm. I looked at the case and I said, what are these other cells with the clear cell changes? And I said it's follicular neoplasm, but there's this another population that I don't know. It was submitted for molecular analysis. It came back as a RAS mutations. When we looked at the search path, it was actually mixed medullary and papillary thyroid carcinoma. And the patients, but naturally you have to be careful because sometimes these tumors can arise very close to each other. So they are not actually, they are just collision tumors. They are not like coming from the cell. But my angioinvasive foci plus the lymph nodes had both components in it. So these are like true mixed tumors, which can be, and they can also be in the setting of MEN or non. So yes, so you can have this. And actually it becomes more common. Okay, thank you so much for being here so early in the morning. And thank you for Nicolina for allowing me to be a part of this. Thank you.
Thank you for joining me, and thank you for everything.